All right, welcome back, everyone. I hope you all enjoyed the breakout sessions and your lunch. We're about to move into session 3, so if the panelists can please make your way to the stage, I would appreciate it. As you all know, the mandate of SDG 3 of ensuring healthy lives and promoting well-being for all at all ages includes supporting systems at the country level to accelerate UHC and pandemic preparedness. Doing this requires strong partnerships, but strong, equitable partnerships at all levels. So to discuss what is being done in this area, I would like to turn things over now to the moderator for session 3, Eric Goosby, the UN Special Envoy on Tuberculosis and a professor at the University of California, San Francisco.
Thank you. Well, thanks, everybody. I hope everybody had some good sessions and are back here for what I think will be an interesting discussion. I think that as we move into universal health coverage and start to think about what are the challenges that are confronting ministries of health and constituencies and the community to stand up a delivery system that responds to the multiplicity of needs that will go across infectious diseases and NCDs, as well as the social service platforms that need to enable and support individuals in the community and populations that need assistance in identifying points of access and strategies that allow those individuals to be retained in care. In order to understand where and who the population is, where they reside geographically, and the delivery systems and responses that have that have kind of propagated themselves in most countries, most cities, most communities. It is a myriad of information that really is unprocessed, not organized. Many areas of activity have been done, and in order not to duplicate what are concerted and strong efforts, the idea of taking the time to understand what the topography of work has been in a given country and to translate that into conduits that allow that information to be accessed so the duplication doesn't occur, but more importantly, that information evolves into a bridge that allows for synergies, cooperation, and partnerships to be defined and then secured. I think that in order for us to reach universal health coverage for the populations that we are trying to attract into care who are not already in care, this becomes a critical tool that we want to think about how to take advantage of. Also, in looking at this data collection, it's not only for the delivery systems and the specifics of the population that do identify areas of access, points of access, but also the issues around security and pandemic control and efforts in that regard. There's a bridge of information data collection that covers both areas, and this type of knowledge sharing is the type of, I think, ingredient that we often don't think about when we stand up programs, but that we all go through a process of understanding and then implementing that would be informed by this. So we're thinking of this as being a missed opportunity, and we're hoping that this discussion will explain this better so you understand the nuances of this and also see this as a potential resource. I am not going to go through long introductions. The introduction material is in your syllabus, and I will leave that for you to go through. we are going to have Rosita Helena, who is going to give us a 10 to 15-minute overview of kind of the area, and then we'll go through a panel discussion where each of the members of the panel will speak to 3 to 5 minutes on a topic. I'll ask a question of them, and then we'll have an open question period for the audience. So, thank you, Rosita.
Good afternoon, ladies and gentlemen. I'm very proud to be standing here for multiple reasons. One, because I'm a member of the working group for knowledge management, and I'm very proud that of all the different working groups in UHC 2030, this is the working group that's been put forth as an important activity or emphasis within the UHC 2030 movement. Another reason, because being the convener of the Joint Learning Network, which is a network of practitioner-to-practitioner learning, such constructs are very important to us to be part of what is the overall very important and very complicated emphasis towards universal health coverage. And then thirdly, from the perspective of a country, I am from Malaysia, and I am with the I'm with the planning division, and my task is to do national health financing reform. I'm supposed to set up a voluntary health insurance agency by July next year, and therefore all these things are extremely relevant in the context of why knowledge management is important. So the working group has been very productive since April, when we first met. There have been desk reviews and interviews completed for the purpose of presenting back to the Universal Health Coverage UHC 2030 Steering Committee on their approval to move forward. And the group did a survey to find out, a landscaping survey, to understand what is out there in terms of the different networks working for universal health coverage. And out of 54 networks, we were able to do 27. And subsequently, we went into deep dives, because at the end of the day, of course, it's very much about what the country needs and listening to the voice of the country. And that's why I feel that we're moving in the right direction, really understanding the challenges at the country level and listening to the demand from countries. Subsequently, the knowledge management strategy has been drafted, and in fact, it was presented to the steering committee just on Monday recently. And the draft, the strategic plan, the knowledge management strategic plan, and also the landscape analysis is available in the UHC 2030 website. So for any of you who would like to see the greater details in that, please do visit the website. But just on a nutshell, out of the 54 networks that we tried to reach out to, we were able to get feedback and input from 27. And then, given the short amount of time, we were able to deep dive and get demands and suggestions from 7 countries further. But I must say that a lot of these networks, again, such as the joint learning networks, is representing 30 countries, so you're already getting a lot of input and information of country demand from the various networks. So understanding what's already available in knowledge management, in the different networks working for universal health coverage, there are the 10 most common technical areas are, as you see, being health policy and systems research, health financing, and governance being the top 3. But perhaps Then there is a role for UHC 2030 to look at the less visited areas and to kind of complement and strengthen those areas. Similarly, in terms of channels and tools used by network, public websites, meetings, conferences, publications, etc., those are well used and are the more standardized methods of getting information towards universal health coverage, but having a searchable database, one that actually arranges and actually codifies all the different information, the quality of information, the structures of the different information, maybe one area that would be important, because I think certainly from the country perspective, when I look for information, there's a whole host of information out there, and trying to sift through this information is a challenge. The other thing would be bringing in, as what was said earlier, most countries know the what. The question now is the how, and working with communities of practice is a key area that needs to be enhanced. So of the 10 common, out of the knowledge products that have been produced by the networks in the last year, there have been courses, learning modules, tools and guidelines and frameworks, and reviews and synthesis of country experiences in applying these tools and frameworks. I think I've heard in the discussion over the last few days, even from Monday when I was here, the concern that it's one thing to hear what a country is doing, but it's to understand the environment and the construct of that application to see whether it can then be replicated into other countries, which is an important area. So doing the deep dive interviews with country representatives, they have identified certain knowledge gaps where they wanted more contents in key technical areas of population coverage, domestic resource mobilization, health workforce deployment and quality, monitoring and evaluation, primary healthcare, of course, governance, and designing benefits package. But there are key cross-cutting challenges that all countries face, looking at practical knowledge resource being available, easily accessed, such as simple case study toolkits and clear how-to guidance. Again, it's all about now how do we do this? Getting a stronger culture of embedding research, and here this is not RCTs, but more implementation research and evaluation research on what are the elements that work in certain countries. And working together to enable countries to leapfrog into the 21st century. We heard from many speakers this morning about the rapidly changing health sector and whether working together through these various networks can actually bring much greater synergism in developing solutions for universal health coverage achievement. So for the strategy of knowledge management, the emerging role for the UHC 2030 is to serve as a knowledge hub, is to connect existing resources and initiatives, a go-to area of resource for UHC. It is to help codify and stratify the right information for the right population or the right, whether you're a policymaker, whether you're a practitioner, or whether you're civil society wanting to get certain information, to provide a rallying cry to leverage knowledge in making evidence-based decisions. And ultimately, to come up with a full cycle of learning what works. And that, I guess, would have to come a little later as UHC 2030 becomes a clearinghouse, but also collecting feedback about the knowledge used and the implementation experiences of various countries as we progress towards universal health coverage. So again, as looking at two main pillars, serving as a connector role for UHC Knowledge Hub, so providing the interface for navigating existing platforms and portals, establishing a central UHC knowledge management virtual hub, so being really efficient in doing this process because the information is there, it's just bringing it together. Online registry of existing platforms and portals so people know who's doing what and where. Looking at setting up an interactive search, filtering the different key terms to make it easily accessible, and organizing health system knowledge hub marketplace, much like what you saw in the marketplace yesterday. There was a very informative marketplace where all the networks were together. In Pillar 2, aligning knowledge management engagement with country demand, understanding and reducing what are the knowledge gaps for countries. So tracking and analyzing the use of the UHC 2030 Knowledge Hub, implementing formal feedback mechanisms, and establishing dissemination channels. So these would be the priority activities for 2018 and 2019 to serve as the connector role. And in the interest of time, I will not go through each and every one of them, but it's there in the strategy plan, which is in the website. And secondly, Pillar 2, aligning knowledge management to the engagement of country demand. This, I think, is the key challenge for all of us, really understanding the challenges that countries face, the how to do things at the level of countries, and how we can help provide the necessary information. So really the two focal points for the knowledge management working group from WHO is Akihito, and from the World Bank is Somil. And that's our website address, where, as I mentioned, the two documents are available. Thank you very much.
Thank you. We'll now go into the panel discussion. We'll just keep the people in the order that we're in. The first panelist is Jeanette Vega, is the director of FONASA, the National Chilean Public Health Insurance Agency. Since March 2014, Dr. Vega has over 20 years of experience in international health. Her areas of expertise include social determinants of health, health equity, and health systems. Prior to being appointed as director by President Michelle Bachelet, Dr. Vega served as managing director of health at the Rockefeller Foundation. She is vice minister of health in Chile between 2008 and 10, leading the country's 13-step agenda for equity in health. Before that, Dr. Vega served as director of the WHO organization, WHO office in Geneva, where she led the equity and health agenda, looking at the social determinants of health and health systems. Dr. Vega, I'm going to ask you a question.
Yes, please.
And see if we can get you to respond. What are the roles of UHC 2030 and UHC 2030 related initiatives in helping achieve the universal health coverage by mutual learning among emerging economies? In addition, what can be done differently in building and enhancing partnerships between UHC in the upcoming years? And finally, are partnerships and initiatives paying enough attention to pandemic preparedness and response, especially for cross-border issues?
Thank you. Well, I believe, as Rosita said, that the main role to help at least emerging economies to achieve UHC is to really become an extremely efficient knowledge hub. You know, what happened now is that there is a lot of knowledge out there, tacit knowledge, I would say. And that happens within countries, but this knowledge is never published, it's never known or shared widely, And most importantly, the failures that we in countries learn are never shared. So what this produces is that we have countries doing exactly the same mistake than other countries that could have been avoided. And then the question is, how do we get this knowledge that is mostly empirical and based on practice, and most of the time learned from failure, to be widely known? So the question becomes how UHC 2030 and this knowledge management platform can capture this knowledge and make it available in a useful way to countries that could face similar problems. Of course, I do agree that the first, the really difficult task is to be able to capture the information from countries, and I would add in real time, because there is no point in having information 10 years after things happened. And then, of course, I don't have to say, but the type of knowledge that we need do not come from the usual channels, such as academia or governmental meetings. Then I agree with you that it would be very useful to have a central clearinghouse that collect this knowledge, but also provide feedback to countries about real-life experiences, and in particular, again, I would like to insist, failures. For example, in Latin America, we have 20 years of experiences in failed health reforms. And that knowledge has not been used, and we can see countries in other regions making exactly the same mistakes that we made 20 years ago. And then a second very important role in my perspective is to facilitate exchanges among countries. But again, not through events or meetings, but by supporting learning networks. Real exchange of best practices among policymakers with real and urgent problems to solve. With regard to your second question, what should be done differently? I think that UHC 2030 in terms of knowledge management should focus on in two main areas. First of all, as I said, create a well-designed mechanisms to facilitate exchanging and learning among countries. And there are examples, very good examples. In fact, you're part of one very good example, which is the JLN. And second, facilitate the supply of knowledge in areas where there is lack of it. Examples. How do we move, do we really move, and how, health system from curative to preventive care? How do we use big data to monitor advances toward UHC? What are the main changes we can expect on health system in the next 2, 5, 10 years due to the massive introduction of digital technology and widely access to information through the internet? In fact, my main worry, as I have said before in other meetings, is that we are advancing towards UHC in a scenario where the definition of one of the two pillars is rapidly changing. What do we mean by access in the 21st century? What would be the configuration of health systems in 5 years from now? We know that the scale of innovation in the provision of healthcare is accelerating. So then, what are the most promising technologies to provide more accessible and lower cost care? How do we use digital disruption to increase health systems efficiency as a whole? How do we get countries to leapfrog into the future using the digital revolution? How do we get the citizens to take control of their health? Now, regarding big data, we know that healthcare data is growing. In fact, it's growing at 48% per year globally. Every 2 days, as much health data is created as was from the dawn of time to 2003. So, how do we use this massive amount of information to advance the UHC agenda? I could go on and on, But the point I want to make is that there are countries in the world experimenting strategies to strengthen the health system of the future in this quite disruptive scenario. We need to capture those experiences very quickly, evaluate them, and share them.
Thank you, Jeanette. Thank you. So the next speaker will be Pavi Silanoki, who's the permanent secretary in the Ministry of Social Affairs and Health in Finland. She was appointed as the permanent secretary in the Ministry of Social Affairs in 2012. The ministry's responsibilities include promotion of health and welfare, social and health services, social insurance, occupational health and safety, and gender equity. I'm going to ask you one question too. So, how can the convergence and synergy between preparedness and the UHC agenda at the country level be strengthened in practice? Secondly, what do you see as the main role for the cross-sectorial multi-actor platforms, such as the GHSA and the JEE Alliance, in helping countries build capacity for health emergency preparedness and response to hazards?
Thank you, Chair. From the gender aspect, I would say that what a strong female power and potential we have here in this panel. So, thank you. To tackle the jet lag and also to keep the time frame, I have put my thoughts on iPad, not on paper here. So in these digital times, so I'm going to read them here. So Finland takes a comprehensive approach to health and well-being throughout the life cycle. And we do so in addition to universal health coverage by addressing the economic, social and environmental as well as political and commercial determinants of health. We underline the comprehensive nature of the UHC concept, covering the full spectrum of essential quality health services, including health promotion and prevention, as well as protection from financial hardship from the use of services. Universal health coverage is not feasible without having in place adequate public health legislation and essential public health functions. This requires also the capacity to work with other sectors. So it's really a capacity to be able to work with other sectors. Sustainably funded, staffed and managed comprehensive primary health service systems capable of reaching the entire population are the best approach to achieving universal health coverage and pandemic preparedness. And that's why I think that it's important that we talk about these three at the same time. The delivery of health services to all and the protection of people from health risks are both rooted in the regular national systems, which need not necessarily be expensive or rely on high technology. A country can develop a strong functional public health system in key technical areas, even if funding is relatively limited. The resilience and everyday operations of health systems, as well as the role of frontline health workers, cannot be underestimated when it comes to disaster risk management and responding to health emergencies. Technical and financial assistance to countries on increasing their capacities to prevent, detect and respond to communicable diseases and other health risks is essential to improving preparedness. Judging from the low levels of IHR compliance and the numerous cases of epidemics spreading into neighboring countries, we are still not ready. National capacities for preventing, detecting and responding to emerging health threats are in many countries insufficient. To strengthen health security and pandemic preparedness, we need to take new approaches. The new process of joint external evaluations already completed in more than 60 countries, and the development of national action plans has been a game changer towards understanding and addressing gaps in national capacities. And here we come to the learning from others' experiences. Several cross-sectoral multi-partner joint initiatives have been launched in the past a few years to address the poor level of preparedness at the country level and to enhance the interagency collaboration at the global level. The Global Health Security Agenda was launched in February 2014 in line with Article 44 of the International Health Regulations to help countries to improve their national capacities. The GHSA is currently a partnership of 62 countries, international organizations, and non-governmental stakeholders. The Global Health Security Agenda has been influential in strengthening collaboration across sectors with different actors and in linking relevant global processes. It has played a central role in bringing health security high in the political agenda and in opening new paths for multisectoral cooperation for health security capacity building. Other initiative, the JEE Alliance, currently co-chaired by Australia and Finland, focuses on supporting the process of developing national action plans based on the JEE evaluations. Since its establishment in May 2016 in Geneva, the alliance has grown into a 65-member platform. The Alliance sees the external evaluations as key sources for evidence and recommendations for developing costed national plans for sustainable health security capacity building. Tying the national plan into the national structures and budgetary planning enhances the sustainability of maintaining the required capacities. And an important aspect of joint external evaluations and the national plans is their transparency. Building regional collaborative models and learning from peers can be conducive to sustainable solutions. It is important to note that WHO has set up a strategic partnership portal serving as a hub for information about both country and donor activities relating to the capacity building in countries. And lastly, as a next step in supporting countries in the process of implementing country plans, the Alliance is supporting WHO to develop, in collaboration with partners, a concept of enhanced financing for capacity building through regional forums, facilitating information exchange and matchmaking between countries and stakeholders. If successful, they can be organized in different regions in the future. Thank you.
Thank you. Thank you. Aku Kwame is a health policy and systems researcher with interests in health systems governance, district level management and leadership, accountability, innovation, and learning in the public sector. Most recently, she was involved in work focused on building the field of health policy and systems research across West Africa. She is a board member of the Health Systems Global and Next Einstein Forum Fellow, an initiative which promotes African science for development. Aku, I'm going to ask you a question. Thank you. From the perspective of academia, what do you see as the added values of partnership platforms such as UHC 2030 in helping achieve UHC by joint learning among countries at all spectrums of development?
Thank you very much. Good afternoon, everyone. It's a real privilege and a grace to be here today, so I'm grateful to the organizers, and I'm grateful to the panelists who've spoken before me, who've really laid a nice framework for the discussion today. So indeed, I do think that partnership platforms such as UHC 2030 present a great opportunity, and particularly from the perspective of knowledge management, I want to respond to this issue of joint learning and how can partnerships like this support the learning for universal health coverage. So we know that we've been speaking about doing things differently and looking at whole system change to achieve universal health coverage. And we understand from this morning's presentation just the sheer volume of data that is being collected, measured, analyzed. And we saw from the slides this afternoon the various networks that are collecting different kinds of knowledge. But we all have to understand that as different stakeholders, whether we are researchers, decision makers, health workers, we all come to the universal health coverage table with our various biases with regards to knowledge and evidence, which are important at which points and when. So a culture around learning is very useful for us in this regard. And we've been hearing more about learning systems, learning organizations, and organizational learning for improved performance. And I did want to just think about this a little bit. What does it mean? We appreciate the fact that our health systems are adaptive, they do self-organize, they do have emergent properties. And so if we are understanding that our best laid interventions and plans may not always go to plan, the aspect of learning is very important in this regard. So with what we've seen on the slides here, we see that evidence and information is not information and data alone. And we know that there are different kinds of knowledge that feed into this. If I give an example from some work that we did studying the policy dialogue processes in African countries for national planning processes, one of the things that we learned from that experience was that participants felt very good about the processes, that they were enablers for sharing information, but they didn't always change the operating procedures of the agencies or of the partnerships involved. And so how do we use all of this wealth of knowledge and different types of information to actually change what we're doing and in fact move towards business unusual? So the question becomes then, how can such partnership platforms actually support new learning cultures? And I see this in a few ways. One is privileging the different kinds of knowledge that we have. So understanding within the 27 networks and even more, what kind of knowledge is being collected, but what kind of knowledge is not being collected. So Dr. Vega made the very clear point about information that we know from failure. And there's a wealth of knowledge and information that we can learn from what happens when we fail. But in very bureaucratized settings like the public sector, like the development sector, we don't have the appetite for failure always. So how can knowledge help us in this regard? How can we use history a bit better? I was pleased yesterday that on more than one occasion, the aspect of having things having worked in the past and those interventions or those experiences they seem to have eroded over time. So how can we learn from things that used to work that work no more? If I use the strengthening district health systems as an example in some of the reforms in our countries in the 1990s. So from the convening and collaborating perspective, what the knowledge management platform can do can also help us to convene around understanding what this evidence and what this knowledge means, what the implications are, and building the relationships. So we all know that relationship building is so important in terms of trust building, working across the system. And so how can we convene around trying to make meaning of the various types of knowledge that we bring to bear? So from the academic perspective, there's the element of using this wealth of knowledge from a research perspective. How can we research on partnerships and learning and moving our various organizations, whether they're ministries, whether they're health facilities, or whether they're development agencies, towards learning systems, if that is possible. And then secondly, from the perspective of teaching, how do we impart new kinds of learning competencies to all of us here as we gather around the table to use this knowledge to achieve universal health coverage? Thank you.
Thank you. Okay. Our last panelist is the Director of International Health Policy Program, Ministry of Public Health in Thailand, and also the Japan-Thailand Partnership Project for Global Health and Universal Health Coverage. She has been with the Ministry of Public Health of Thailand as a senior researcher of International Health Policy Program since 2001 and was recently promoted to serve as the director of IHPP 2017. Since joining IHPP in 2001, her research perspective has broadened from the hospital level to the national and regional levels. I'm going to ask you a question too. As one of the UHC champion countries, how has Thailand engaged partners within and outside of the country to help achieve universal health coverage? What are innovative approaches of the Japan-Thailand Partnership Project for Global Health and Universal Health Coverage as one of a triangular cooperation initiatives? To what extent, geographically and thematically, do Japan and Thailand jointly support other countries with their own experiences and lessons learned?
Thank you, Kat. Thank you for allowing me to participate in this session. Before going to answer the specific question on Japan and Thailand collaboration, I would like to give you an idea and the opinion from our experience of having several partnerships among many networks. Similar to other Thai health system gets to be more and more complex. We are working not only within the Ministry of Public Health, but also with other ministries. Apart from the ministry, we also need to work with the local government unit, private sector, community, society, etc. This is within a country. You can see that how many networks that we have within a country. Outside the country, we also have several platforms and partnerships similar to the UHC forum here that we are come here. And we have several platforms and opportunities to engage ourselves to many of you. My key point is that we have so many networks and opportunities. We need to manage ourselves very well, not to go crazy and lost focus. Indeed, it is very important to manage. This knowledge management opportunity would be useful and effective when we have trusted network, share vision, and mutual benefit together. Apart from the knowledge, we have heard from the previous panelists that capacity at the country level to act, to implement is very important. And then one of the key message for me to several of you, including the development partners and networks, is to build up national capacity and institutionalize them and support them to work with their own country context. So it is not difficult to do that. I give you an example of Japan and Thailand collaboration on global health and UHC. We call in short GLO UHC. With the three outputs that this project aims for. The first one is to build up capacity of Thai staff using Japan experience and other experience. The second output of this project is to collectively combine the effort of Thailand and Japan to support the other country. The third output is to support and drive agenda and the implementation on UHC and global health at the global level and regional level. We act within the country, support the other, and at the global level. Another example is recently, just today, the collective effort of many countries led by Foreign Policy and Global Health Initiative at the UNGA. The resolution on International UHC Day just was adopted this morning at the UNGA. Many countries support this resolution, of course, Japan and the country within FPGH group and other countries around the world. These are the two examples that we can have a mutual benefit of the partnership that we already have and maximize it. This is only a small example, but we can gain more from you all. Thank you very much.
Well, thank you. We're going to open this up to the audience so people can start thinking of their questions or comments that they'd like to make. I think this has been a eclectic demonstration of a variety of different perspectives on a problem that I think we've all struggled with. Data collection in general is an expensive and time-consuming effort, and to think of ways that we can make that information available to those who can use it, as our panelists have said repeatedly, in real time, becomes the critical factor. To wait months or years even to access this data may have some relevancy, but the correct policy decisions are best informed when they're making them based on information in as close to real time as possible. I think that the response to pandemic preparation, the ability for countries that are often in front of an outbreak to be able to recognize the outbreak and bring it to the ministry, and for the ministry then to report it to multilateral WHO to stimulate a response of both a strengthening of surveillance and to mobilize resources to respond to it, needs to be seamless. And I think also is in great need of support at all levels of that continuum of that information movement. But I do think that our ability to support countries as they're struggling with that needs to be part of what we think about. Could the panel react to some of those challenges as we move both in information about delivery systems that we have developed, but also about outbreak management and movement of that information both within the country and kind of heading toward Geneva and New York? Any thoughts on that? Not really, huh? It's okay. Okay, I'll keep that to myself. Are there any questions that the audience might have about the knowledge management? Do my panelists have any thoughts that they wanted to add to what they heard their colleagues speak to elaborate on a little bit, please?
Oh, sorry. Yeah. As I mentioned earlier, I wear multiple hats, and speaking from an upper middle income country, I think there's a lot that countries such as Malaysia can share with the world, and there's a lot also that countries that we can learn from others. But we're seldom involved in anything that the development partners want to know. And so I think having a UHC 2030 platform which straddles all income levels would benefit countries, one. Second, what Jeanette said about learning from failures or sharing failures. It's very, very sensitive for a government to admit failures. It's very difficult, and you certainly won't see it published anywhere. So platforms like the Joint Learning Network, which creates a safe space for practitioners to talk openly about their failures, to share with other countries what not to do, or what has been their bad experience, and then learning, how that was overcome, etc., has been, very, very effective way of really moving from the talk to the walk. And then as a member of the UHC 2030 Knowledge Management Working Group, I think that this construct should be seen as a network of networks. It's not to subsume others, neither is it to create its own monstrosity. It's really to bring together efficiently information that's already there in a much more accessible and constructive, systematic way.
Well, the thing though is that when we create a structure, we have the risk of sort of responding to the structure and not to the problem. And I always get a bit worried when we create a new alliance or partnership or anything, because we are really talking here about the reality of people not accessing to health services or not having financial protection. And the time is very short. So the only way we are going to get near there is if we really share what we know, what are best practices, and what do not work. Now, of course, there are a lot of complexities. One of the complexity, of course, is that we are talking about the very different landscape. We're talking about countries that are extremely deprived and other countries that are in sort of in a different stage. And then one additional question that I want to pose again is that if we already know that there are things that do not work, if we already know that the configuration of health systems is going to be a completely different one, why should we be advocating for creating systems that we know do not necessarily work? In other words, for me the question are, what is the real configuration of an effective primary health care level? And for me, the configuration is as close at home as possible. And then the second question becomes, what of the things that we do right now that people have to go to where we are could be done at home? Because we are having a complete transformation in terms of technology, communications, access, and so on. So why we in the health sector are still so inefficient compared to other sectors? Look what has happened in the communication sector. Look what has happened in the computing sector. Look what has happened in the bank sector. And we are still sort of continuing talking the same over and over, building blocks of the health system, when the thing is, how do we make services to people, around people, using the best resources we have? And that's the real question. It's not I use prepare. I mean, fine. That's the least we can have. But then let's move on and think of the system that we really need to solve the problem of access to care for people that are not getting with financial protection, but in reality. Mm-hmm.
Please. And then we'll take a question here.
Yeah.
If we can get a microphone there.
Yeah, good comments. I would say this is it depends a lot of your attitude, as you said here, that and where we focus, that we have to focus on people's need, and when we are solving those problems, then we need teamwork. No one can't do that alone. no specialist can alone be there. So it's to take the people-centered approach. And then also that our attitude is that we are in learning process here all the time. So then we have a totally different kind of mindset if we are learning and learning by doing then. And then I would like to mention here the joint external evaluations. The beauty of them is that there is a multi-sectoral team, an external team coming to the country who has done their own assessment there at the country level, and then there is a peer-to-peer discussion, and also those who come into the country, they learn. And we have had that kind of inspection type of evaluations before, and they don't help countries to commit as those peer-to-peer discussions help countries then to commit themselves. Because those who come to inspect, external evaluations who come to inspect, they don't understand so much why those why countries have solved their problems and why they have that kind of solutions there at the country level. So it's really the beauty there that there are discussions going on, and there is an open mindset of knowing.
Let's take this question here, ma'am.
Thank you very much. My name is Oanh, and I'm from Vietnam. I work for local NGOs in Vietnam. I am also involved in the civil society engagement mechanism for UHC 2030. I think the knowledge, we can talk about knowledge management forever, unless the community, the people embrace the knowledge, absorb the knowledge, and grow the knowledge. The UHC agenda has been heavily government-driven. Eric, you've been the Global AIDS coordinator. You've been to many HIV/AIDS meetings, and you can see the difference between the atmosphere of this meeting and the HIV conference, for example. There's a very little civil society participation in this meeting. It has been very, very government dominant. And we, in Vietnam, we have saying, officers are short life, temporary. People are forever. If we rely only in the government change. Look at what happened in the US. The first thing Trump does is to repeal Obamacare. So government change, and with the change of the government, the change of policy. But people stay, and even if the government, there's an even country that there's a quite stability of one political party. The officer change. Today you have one minister. Next year we have another minister who have a different priority. So if we want the UHC agenda to be lasting, to be really being realized, to become real, it has to be embraced by civil society and the population. So I think we should, because now we talk about health for all. And this year we celebrate 40 years of Alma Ata. 40 years. 40 years ago, we set the goal for health for all by 2000. And now we are 2017. We are still talking about health for all. And half of the world population still don't have the service they need. So I think it's time to change course. We will never achieve health for all unless we engage with civil society and community. So, yeah.
Thank you. That was powerfully said, and I think speaks strongly to the issues that I believe are in front of us. The resilient systems that I have seen stood up have always required an ongoing and continuous dialogue with community at both the planning and the implementing level. And until that is in place, you are driving a boat that has many options to dock. Political leadership is constantly in front of many unmet needs, and those unmet needs begin to blend together, and it's difficult often for leadership with the best intentions to effectively and accurately prioritize those needs. It needs to be in a dialogue with the constituency that is not only looking out after their own interest as a constituency, but also incorporate the larger community and society in general. That can only be achieved with a dialogue from political leadership and community. So I really want to reinforce everything you said. Another question. Are we supposed to stop at 4:30? Oh. Oh, you were really about to be in trouble. I was going for 5 o'clock here. So I will ask my panel if there's any summary statements, please.
Thank you very much for the comment from Wang from Vietnam. As Thailand moved UHC reform, with the strategy of triangle that moved the mountain, knowledge is one angle. We need to be supported by social mobilization, civil society come in to be an important. Another angle that is very important is political point of view or the policy leadership, that we need to harmonize and synergize the three angles together, and then we can move something that difficult to be possible. Thank you.
Thank you. Anyone else on the panel want to summarize anything? I think we've done it. Well, I'd like to thank the panel for their thoughtful comments and the time they put into the preparation. Thanks you to the audience. If we could give them a hand. And that will end the session. Thank you.
Thank you very much for a very fascinating panel. I'm sure these are issues that we're going to continue to revisit for the rest of the forum. You can go ahead and we'll have the next panel come up. Thank you. Before we start the final session for today, I wanted to just go over a couple of logistical matters. First, there will be a reception this evening at 6 o'clock. It's hosted by the government of Japan and the World Bank. It's at the Tokyo Prince Tower Hotel, which is very close by. It's about a 10-minute walk. There's a map in the back of your program book if you want to walk over there. Otherwise, there's also a shuttle service that will be available from the main entrance of the hotel from 5:30 to 8 o'clock. The second item is that we will have added security tomorrow morning because we have heads of state. So you will need to go through a metal detector before entering the venue tomorrow. Therefore, we request that everyone arrive no later than 8:45 tomorrow morning so that you can go through security in time. Unfortunately, anyone who is not cleared by security before Prime Minister Abe arrives may not be able to enter the venue until after the first session is over. So I highly encourage you to come on time tomorrow morning, and we really appreciate your cooperation with the security screening. So now, without further ado, I would like to hand things over to the moderator for the last session for today, Ole Dibawada, who is the Director of Human Capital, Youth and Skills of the African Development Bank.
Thank you very much.